trying to do too much, or actually I've seen in some instances people doing too little. Too much, too little. It's got to be just like Goldilocks, do everything that must be done, nothing that doesn't need to be done.
Enter the world of military trauma surgery with Frontline Surgery, where we bring you expert insights and real-world scenarios to help surgeons stay ready.
Brought to you by the AAST Military Committee. Join us as we engage in conversations with field experts, examine critical battlefield scenarios, and uncover the strategies that keep surgeons ready for anything.
Stay prepared and stay sharp with Frontline Surgery, where every episode provides key insights into mastering military trauma care. Welcome to another episode of Frontline Surgery, Mastering Military Trauma Care. I'm Joshua Dilday. I'm an Army trauma surgeon.
And I'm Matt Eckert, a retired Army trauma surgeon, Josh's co-host.
And in this series, we help prepare early career military surgeons for the reality of deployed trauma care. We share key insights from those who have been there, like today's esteemed guest. Today, we are focusing on damage control surgery. Now, this topic is well known, well heard of, and a key part of the lexicon in any military surgery lingo. And it's a key skill set for those deployed surgeons facing massive injuries under austere conditions. And because of that, we hand-selected this guest from the very beginning of planning this episode. We are honored to be joined by none other than Dr. Jeremy Cannon. He comes to us with an extensive wealth of knowledge and experience in combat casualty care and brings that deployed surgical leadership perspective to this discussion. Dr. Cannon, thank you so much for joining us. We're honored to have you.
Josh, Matt, thanks so much for the invitation and for that very generous introduction. Looking forward to the conversation.
Well, let's get right into it then. We're going to begin with a little operational clinical scenario, Dr. Cannon, and just to set the stage for you. You're a surgeon at a Role 2 surgical facility in a forward operating base during a major offensive operation in a dense urban environment. No challenge there. A casualty arises after a building collapse following an enemy rocket attack, has multiple penetrating torso injuries. He's got signs of abdominal compartment syndrome and severe hemorrhagic shock. The evacuation route, unfortunately, to your Role 3 is threatened by enemy indirect fire, so you may need to hold on to this patient much longer than you'd like to. You have one other surgeon to help you, one operating theater, limited blood supply, and the next wave of casualties may be on the way.
Now, Dr. Cannon, that scenario is unfortunately very realistic, but extremely scary. What are the first priorities when you're hearing that through? When this patient rolls through the door or the tent or wherever, what are the first things that go through your mind?
Well, I would say a very challenging scenario for sure. But, I think this is the kind of situation that really pushes you to be a better surgeon, to be a better leader. I'd like to back up just a little bit and lay some groundwork. There's a famous saying that chance favors the prepared mind. So, you've got to have done your homework, your prep work, have had your nose in the book of frontline surgery, of top knife, of emergency war surgery before you ever find yourself in this situation. If you do not, you will feel extremely out of your depth, appropriately so, and your patients will suffer. So it's vitally important to have mapped this out, to have visualized what it's going to look like, to have met with and really bonded with your team before you get into the situation, because it's going to be a real strain on not just you as the team leader, but on your colleagues that are part of this role too. So in addition to the resources I mentioned, I would also commend the landmark study from 1993 from my current institution, my trauma home at the University of Pennsylvania by Mike Rotundo, Dr. Bill Schwab, and colleagues about patient selection for damage control. So that's a 1993 Journal of Trauma landmark study. All trauma surgeons should know the ins and outs of that study, know the patient population to which damage control applied, and then should understand the results. Then the challenge is, how do you translate, this fantastic study from many years ago in a civilian setting into the modern combat environment? So what are your priorities? What's going through your mind as this patient's about to roll in the door? I would say you've got to pre-brief your team, understand what your resources are, and as much as you can, understand what the likelihood of additional casualties is. I always say that you got to treat the patient in front of you, not the ones that are outside the door about to come. But I think having some situational awareness is vitally important as you prep the battlefield, so to speak, getting ready to try to outmaneuver the ultimate enemy, which of course is death.
So true. The scenario that we painted for you, obviously very challenging. But thinking about that patient coming through the door with that constellation of injuries, what goes through your mind of your initial steps to save this patient?
Yeah. So, to go from the very general to the much more specific, in your frontline surgery podcast series here, I know you've got an episode on damage control resuscitation. That has to be the yin and yang with damage control surgery. You have to have an alive patient, and ideally one that has not lost their pulse at any point along this journey. So vitally important to follow the precepts of damage control surgery that you discussed with Dr. Holcomb. I'm very quickly doing the XABC, so looking for exsanguinating hemorrhage, anything compressible on an extremity that doesn't have a tourniquet. I'm going to try to apply a tourniquet there. And then I'm going to initiate my resuscitation as I assess the airway, check for how well they're breathing, and then getting my vascular access or IO access. In a combat environment, you may also consider a sternal IO. If there are traumatic amputations and you're struggling to get central access, a sternal IO can be a good option, or a central resuscitation line, strategically positioned away from the site of injuries so that your blood products aren't, going into a body cavity or onto the floor. So you have to be a little strategic about where you put your access and then proceed from there.
Dr. Cannon, you're talking about a military scenario, and the article that you mentioned, despite having its reference name with military history, with Navy damage control, but it's a civilian paper. So we're in a military setting. You're talking about a civilian paper. Are there differences with that austere environment, with that military setting, with that patient that might change how these damage control principles are, or are they exactly the same?
Yeah, great question. And, I think this is the crux of sort of the mentality that you have to have when you're in a deployed environment. I learned all this great stuff in a civilian setting. I may have seen some patients that were severely injured like this, but I had, all the resources I could ever want. I had almost a, bottomless blood bank. I didn't have 5 or 10 or 15 other casualties on the way. Probably had a much more robust team, both in the hospital readily available and probably a few backup, first and second backup surgeons. So how do you translate all that? I guess first I want to talk a little bit about the indications for damage control in the operating room. So we talked about damage control resuscitation, how that fits together with damage control surgery, all the elements that hopefully will lead you to the operating room. The scenario you set up, the patient's probably got intra-abdominal hemorrhage or near exsanguination. So you need to be in the operating room ASAP. As a good friend of mine during my second deployment, Cabot Murdoch, used to say, nothing we're doing here in this trauma bay is stopping this patient's bleeding. That he was exaggerating for effect because, we probably had put a tourniquet on, but, to his point, you got to get to the operating room. So, have you already contacted the OR charge nurse, anesthesia, your CRNA or anesthesiologist ready with, to take over the resuscitation? So that team needs to be ready to receive this patient as you're focusing on cavitary triage and getting into the heart of this damage control approach. So there's thoracic damage control, there's abdominal damage control. We got to figure out what cavity we're going to be in. That would be with FAST and probably some X-rays in your resus area to figure out if there's a trajectory that goes across the abdomen. Do I have a big hemothorax that I need to drain or explore? So you have to do some cavitary triage. Unfortunately, that can be challenging, and you have to be a little semper gumby. And if you find that you're in a cavity that doesn't have a lot of blood, you gotta quickly shift gears and go to where the bleeding is. So we're in the operating room. I'm thinking about the fact that I'm in a combat environment. It's austere by definition. We don't have endless supplies. We don't have endless blood products. We don't have, we may not have all the fancy staplers that you're used to and all the other gizmos that, make our lives, quite honestly, pretty easy, pretty enjoyable in a civilian setting. So first of all, blood, you probably have will want to activate the walking blood bank at this point. If you're in a damage control mode, that takes a while to spin up. Certainly let your blood bank know that you're going to be drawing on their inventory. Let's say that you're exploring the abdomen. So, rapidly get in there. I tend to, if it's like undifferentiated penetrating trauma, tend to pack all four quadrants. If it's more focal, you can sort of just pack the quadrant that's affected. Then I, let anesthesia catch up a little bit, and I'm doing my supramesocolic, inframesocolic assessment. Then I'm looking at the retroperitoneal zones, trying to determine, is this a upper abdominal problem that I need better access for? Is this an inframesocolic mid to lower abdominal problem? And then, what are my exposure techniques to get to the problem? So, once you find all your injuries, then you have a decision to make, open abdomen or not. And I'll say, for your listeners, that's very well covered by Chapter 12 in Frontline Surgery by some great friends and colleagues, Amy Bertries, Craig Shriver, and Ali Salim. They really covered this topic well about that critical decision of, do I close, do I open? And if I'm leaving the abdomen open or the cavity open, how do I do that safely?
And we'll make sure we drop those in the show notes, because that couldn't be said any better about having that reference chapter and some other guidelines. And I love the phrase "semper gumby." I think that sums it right up. For those that's being flexible. But the military community will have heard that a ton. So that was well said and summed it up. Thank you, sir.
Jeremy, that's great. And I'm thinking of, day in and day out, we operate with all the modern conveniences in the OR. But thinking back to those days in a tent when there was no more IABAN, there was suddenly no more staplers. What are your tips on what these young surgeons can use in the future to make do?
Yeah, that's really the heart of being an expeditionary surgeon. You got to know, what's at your disposal, and when something you're used to using or expecting is not available, how do you bridge that gap? This is an example where it's very helpful to sort of have planned this out or war gamed it a little bit mentally. I'll give a couple of examples. So, of course, the priorities for damage control surgery or any emergent exploration for trauma is control the hemorrhage and then control the contamination. And I would say control the hemorrhage is like, 1 through 8. And then 9 and 10 is control the contamination. Like the patient is not going to die of fulminant sepsis in the next 6 hours, but they are going to die of exsanguination. So got to control the hemorrhage and then control the contamination. So you do your abdominal assessment. You find where the injuries are. You hopefully have clamps on the major named vessels that are exsanguinating, and you've started to identify your bowel injuries. So let's talk about the vessels. What if you don't have a clamp? Like you looked and thought that you had clamps, but suddenly they're not sterile, or they fell on the floor. The sterilizer didn't work that day, or whatever. So think about how you would control a vessel that's exsanguinating without a clamp. So you can use a Rommel tourniquet, which is basically an umbilical tape through a piece of rubber tubing that you loop around the vessel and then cinch down. You don't need a fancy DeBakey clamp or something like that to control the vessel without injuring it. So that's one example. Let's say you're ready to shunt and you ask for that shunt that I always use, and they bring up, an array of different things, and none of them seem to fit. What can you use? You can use a cordis, a resuscitation line. You can use an IV. You can use a nasogastric tube. That's really sort of getting off label here, just, truth in advertising. But anything with a lumen can be trimmed to size and used as a shunt to bridge a gap in a vessel. What about bowel injuries? So quite honestly, I like to staple them off. It's very quick and quickly controls the contamination. And I use a ligature to control the vessels in my civilian practice. But those are all nice to have, not must have. So I get around the bowel in an austere environment. You can get around the bowel and use that very handy umbilical tape once again to just tie off the bowel. Now, be aware, don't leave umbilical tape behind. So I would leave a very long tail that's so obvious that anyone can find it. you'd be surprised because you'll be handing this patient off probably to another team. So make it so easy that they just simply cannot miss it. So very long tails on the umbilical tape. Controlling the mesentery. I mentioned the ligature. You don't need that fancy energy device to control the mesentery. Clamps of any sort and sutures and ties work just fine and have for centuries. So hopefully you'll have those absolute basics. If you don't, you'll have to get really creative to control the vessels. But I'm hoping you've got ties or some way to control the mesentery without an energy device.
So you just laid out a ton of things that, one, I currently don't do in my civilian practice. So maybe I should be doing these. But you gave us a lot of tips and a lot of key components. What about the other side? When I'm in that scenario and I've got Dr. Jeremy Cannon's voice on my shoulder as the good angel saying, make sure you don't do this. What are those key mistakes that, as the early career surgeon, I have to avoid in these scenarios?
Yeah, great question. And there are so many pitfalls and booby traps and opportunities for failure, which is in part why it's so important to think about the entire scenario from patient arrival through the alive patient going to the ICU before you ever get in that situation. I'll start with the patient in front of you first. Trying to do too much, or actually I've seen in some instances people doing too little and leaving, say, a vena cava injury fistulized to a renal artery that you then discover on CT scan, and then it's like a rapid return to the OR. So too much, too little, it's got to be just like Goldilocks, do everything that must be done, nothing that doesn't need to be done. So again, getting back to first principles, you're controlling hemorrhage, all hemorrhage. So do a thorough investigation of the cavity and control it all. And then, all sources of contamination. So, to harp on the theme of thoroughness, you need to go from the GE junction, look in the lesser sac, run the entire bowel a couple times, make sure you're in many, if not most instances or all instances, cocorizing the duodenum, mobilizing the colon a little bit to make sure they're not little frags hidden here and there, because in this scenario don't necessarily have the benefit of early rapid cross-sectional imaging that will show you some of those things. So you got to use your eyeballs and make sure you're seeing all those areas. So don't do too little, don't do too much. So not doing too much, make sure you're in communication with your anesthesia team about how the patient's doing. Make sure you're also keeping track of that ratio of blood products and how much blood is going into this patient. You're checking in on the lactate and what is the trend looking like there. Has a tag been sent to deal with any coagulopathy? So not doing too little, not doing too much for the patient in front of you. And then that situational awareness on a small team like this, out in the middle of nowhere, even though it's an urban environment, you're sort of at the end of the resupply line, and there are probably not other, immediately accessible medical units close by. You got to know who else is coming in the door. You've got to, understand who else is in the ED. Is it time to pack up here and go to the recovery unit, or can I keep going a little bit more? So situational awareness, who else you need to assess. So that just a few things to consider as you're forging along in this operating room battlefield that you found yourself in.
And that's a phenomenal point that I hadn't really thought about until you brought that up, because I think a lot of the trauma surgeons in this environment, they may feel very comfortable with a lot of these injuries. Now, maybe not the injury that that we described, but some basic trauma stuff. How does that trauma surgeon stay within their lane of the environment without seeing injuries that they are so used to repairing, given the time that they are accustomed to having?
Yeah, I think that that's a great point in terms of, most often I think about that in terms of injury evolution. So you don't know the kinetic energy behind these fragments or missiles or sniper rounds or whatever caused this injury. And most often it's going to be a high energy kind of situation. And the injury that you see today may not be the injury that manifests tomorrow or the next day in terms of how quickly or how far things progress. So, we often think about that in terms of extremity wounds, that, you're surprised it's for the cavitation in an extremity or the amount of destructiveness that you identify when you open things up. But it's absolutely also true in thoracic injuries and abdominal injuries that, that pinhole in the small bowel, may completely necrose by the following day just because of the kinetic energy behind the injury. One example I'll give, just talking about my own experience and how I learn from tough miscalculations or bad assumptions. So we had a patient that had a thoracoabdominal injury, but it looked sort of tangential, and I was promoting, just pop a scope in and take a look, transabdominal, and the senior trauma surgeon that was deployed with me said, there's no way this is minimal, and there's no way it's just tangential. We're going to go, all the way. And I think we did a transthoracic approach. We just went, right through the zone of injury. And sure enough, the diaphragm was in tatters. Like, I was astonished. And I should not have been. I mean, I should have been thinking, we're in a war zone and things are high energy here. And that's sort of the norm. But just to see it live and in person was really astonishing. And we, needless to say, ended up doing a damage control approach on that situation because there was really no diaphragm to work with. So we did a temporizing thing, tried to partition the cavities off, and did our best. I would say, for our younger colleagues listening to this, damage control is going to be your default in most cases. And that's really because the injuries can be much more extensive or extreme than you expect, and they can evolve pretty dramatic.
Wow. Those points are so good, Dr. Cannon. I think back to the first times I saw patients that had dozens of holes in them and thought, where am I going first? And I think your points on thorough exploration, but always keeping in mind, I've got to find what's killing my patient and then not spend extra time here and get them off the table. This is really pertinent. As these young surgeons start to prepare themselves for the future, many of which are not going to have little or no deployment experience behind them, from your perspective, what are some things they can be doing to prepare themselves now as they think about these, unknown, challenging situations of the future?
Great question. I talked a little bit about your mental preparation and then, as you're on site, bonding with your team. There's really no substitute for that. You got to have a solid foundation of knowledge and rapport and collaboration with your team. But then I'd say, as Colonel Gurney, our intrepid Joint Trauma System director, often says, experience matters. You have to get in the operating room and have seen this and experienced this to understand the right and left boundaries of what is feasible versus what is reasonable, what are the upper limits of what's possible. And there's truly no substitute for having experienced this firsthand or led these operations as the lead surgeon. So if you're in a situation where you don't have a lot of access to these patients, I would work aggressively with your leadership to get into a situation where you can have these sort of exposures. We've got an active duty Navy trauma team with us at the University of Pennsylvania, and that is our highest priority, is to get our Navy trauma team, these experiences, and not just for the surgeon, but for our anesthesiologist, for our emergency medicine physician, our medics, they call them corpsmen in the Navy, our ICU nurse, our ED nurse, they all need to have this exposure. So no substitute for experience. Jennifer Gurney says it best, experience matters.
There you go. We've had Dr. Cannon quote a chapter from Frontline Surgery, Rotundo, Schwab, Jen Gurney. I can't think of a better episode than that. Dr. Eckert, Dr. Cannon, any last points of advice that you want to give to the listeners? Because this episode has been chock full of pragmatic, realistic scenarios and advice, and I can't imagine anything better. So the floor is yours. What else do you want to close with here?
I would just say, you mentioned IOBAN running out. You got to think about the closure. So it's one thing to say, I'm going to temporarily close this abdominal cavity, and then it's another thing to actually do it. We in the U.S. rely, I think, pretty heavily on the Apthera device for temporary closure, but you're unlikely to have that in this sort of setting. So you've got to read the books about how it's done without all the bells and whistles. It can be done, and it can be done well. One key is don't let the bowel sneak out under the drape. Whatever you apply. I've got a new name for that I'll share with your audience. So you've heard of gastroschisis. For the pediatric surgeons, you'll know what that is. I call this phenomenon where bowel sneaks out around the vac, leading to an early take back to the OR, bacroschisis. So don't fall victim to bacroschisis. Make sure your closure is solid, and then come back to fight another day.
Love that term. And we'll use that as early as tonight on call. Dr. Eckert, anything else that we missed? Because this was awesome.
No, it's wonderful. Thanks, Jeremy, for sharing some of your experience and tips. I think they'll go a long way for our young surgeons as they face the great unknown in the future. I thank you to everyone for joining us on Frontline Surgery, Mastering Military Trauma Care. Damage control surgery saves lives by prioritizing what matters most, getting patients through their first operation alive. And we hope today's discussion gave you some practical tools and perspectives to prepare for these challenges on the battlefield of the future. Until next time, stay sharp, stay ready. Thanks again, Jeremy.
That was really great. Stay sharp, stay ready. I love it.
Thank you for tuning into this episode of Frontline Surgery. We hope today's discussion has provided valuable insights into military trauma care.
Be sure to join us next time for more expert perspectives and battlefield-ready knowledge. Until then, stay ready.